Hi, followers of Neuro Takeaway. Welcome back to the channel. Today, we are going to talk about and try to update pediatric cerebellar and fourth ventricle tumors. And in doing so, we have to remind that last month was published the latest classification of tumors of the central nervous system by the WHO. And as in the previous one, they stressed the importance of a layered report structure, where we have a histological diagnosis, grading that now is with Arabic numbers, and a molecular information, which is more and more important. Here we have the first tumor, which is the most important in pediatrics in the posterior fossa, the medulloblastoma. It's a malignant tumor. It's the second cause of death for cancer before the age of 15 years. It's an embryonal tumor. It's a high grade with grade 4 for the current classification. It occurs between the ages of 5 and 10 years in most cases, but we can find it in infants and in adults. There is a second peak between the ages of 20 and 44 years, and it is usually sporadic. It has, unfortunately, a tendency to disseminate, and we have dissemination in around 30% of cases at diagnosis. Now, embryonal tumors are divided in medulloblastoma and other embryonal tumors, and medulloblastoma can be diagnosed with the molecular profiling in 4 groups: the wingless activated, the sonic hedgehog activated, which has 2 flavors, TP53 wild type or TP53 mutant, and this distinction is very important because they have completely different prognosis, being the TP53 mutant more malignant, and finally the non-wingless, non-sonic hedgehog, which represents groups 3 and 4 of the radiogenomics. But we can diagnose medulloblastoma without molecular profiling in the classical histological variants, classic desmoplastic nodular, medulloblastoma with extensive nodularity, and large cell anaplastic medulloblastoma. This classification mentioned the importance of the subtypes according to methylation and transcriptome profiling, especially with respect to the sonic hedgehog activated group, because there we have 4 subtypes: alpha, beta, gamma, and delta, and they may have different prognostic and therapeutic implications. Let's start with imaging. When we talk about imaging for these patients that come with nausea, vomiting, headache, ataxia, we usually perform first CT without contrast. And what we find is a posterior fossa tumor, hyso or hyperdense with respect to the parenchyma, sometimes with calcifications, but not usually, around 5 to 10% of cases, and associated with the hydrocephalus. Look at the density. This hyperdensity of the tumor has to do with the histological findings. It's a tumor with a high density, high cellular density, these round blue cells with high nuclear to cytoplasm ratio, and the presence of hydrocephalus is important, and we have to look at these small nodules that sometimes unfortunately happens that are metastasis, and they are isodense with the parenchyma. This property of being isodense to the parenchyma may make us get confused with the presence or not of this tumor, especially in cases where there is no hydrocephalus. And we have to take into consideration the presence of artifacts in the posterior fossa. So we have to be very aware of this. And obviously, MR is much more sensitive. We can see this enhancing tumor with spinal dissemination. Regarding MR, the tumor is usually has a hypointensity on T1, iso or hyperintensity on T2 and flare because of the same property, again, the high cellular density. It is associated with restriction on diffusion, which is a very, very important characteristic, and the pattern of enhancement may be variable according to the group, as we will see later. Well, regarding the metastasis can go up to the subependymal region of the ventricles, or they can go down to the spinal, to the spine. Regarding these metastases, we have two patterns. One is the match pattern, as in this case, where the enhancement is positive and the diffusion restriction is positive. So this is a concordant pattern. And we will see later another pattern. Regarding MRS, may help sometimes. We can find this peak of taurin at 3.3 or 3.4 ppm left to the peak of choline. This peak is present in almost every medulloblastoma, with some exceptions regarding the sonic hedgehog activated group. We also find high choline, and in the localized medulloblastoma, we can find mobile lipids and lactate, as in every malignant tumor. Medulloblastoma was one of the first tumors associated with radiogenomics, which is the possibility of predict or trying to predict the molecular characteristic of the tumor looking at the image. In medullo, we have to take into consideration the topography, the enhancement pattern, the presence or not of metastasis and their characteristic, and the presence of hemorrhage. Here you can see we can start with the wingless variant, which unfortunately is the less frequent because it's more benign. It represents around 10% of cases. It occurs in children and adults. It's rare in infants. There is no predominance of gender. The prognosis, as we said, is very, very good, with more than 95% of survival rate at 10 years. The metastases are infrequent, and including when they are present, the prognosis is good. And the histology is usually classic medulloblastoma, and the cell of origin is the lower rhombic lip progenitors. Here we can see the Wnt pathway that starts with the Wnt protein, the Frizzle receptor, all the proteins that are regulating beta-catenin, which is usually disrupted by the proteasome, and any alteration of this regulation can trigger the translation of beta-catenin to the nucleus in order to activate the transcriptional factors. Traditionally, we consider this group as tumors present in the cerebellopontine angle or in the middle cerebellar peduncle with an enhancing pattern. But now we have other options. For example, Sultan Patai published this paper where he divided this wingless group in 4 subtypes. Subtype A with a midline interventricular topography, subtype B with an extraventricular, midline extraventricular localization, subtype C of midline intraventricular and subtype D of midline extraventricular, which is the type that we saw before. And the reason why this tumor may appear in all these localizations has to do with the migration of these lower rhombic lip cells along this anterior pericerebellar extramural migratory stream. The German group published their experience with this medulloblastoma, and they saw that around 75% of cases, this tumor is located near the midline, especially in a paramedian midline region. And they found a high proportion of hemorrhagic content in this localization, around 60% of cases. We had a similar experience in Garrahan. We've seen several cases of this midline wingless tumor with hemorrhage, as you can see here on SWI. The second group is the sonic hedgehog activated, and this represents around 30% of cases. The age of presentation is in infants and in adults. It can happen in both extremes, and there is no gender predilection. And the cell of origin is the upper rhombic lip granulocytic cell progenitors, which will form the external granular layer. That's why this tumor occurs at the periphery of the cerebellar hemispheres. The prognosis is variable. We talked about the differences between the mutation or not of P53. The border are variable. There is intense enhancement, but sometimes irregular. There is an association with the desmoplastic variant, as well as with the extensive nodularity variant on histology. It tends to be multifocal, and there are mutations in any of these proteins that are present in this pathway of sonic hedgehog, patch, smoothen, or SOFO. And finally, you have Gli, which is the protein that goes into the nucleus to activate the transcriptional factors. Regarding the images, we find this tumor in the periphery of the cerebellar hemisphere with an irregular pattern of enhancement, irregular presence of restriction on diffusion. Sometimes we find this grape-shaped nodularity, which is very helpful. Look at this multilobulated tumor in the cerebellar hemisphere associated with restriction, but with an irregular and heterogeneous pattern of enhancement. Here we have another case with multifocal nodules. This tumor has the characteristic of relapse at the same localization of the primary tumor. There is usually there is no dissemination through the CSF. Let's go to group 3. That is the worst one because the prognosis is bad. It represents around 25% of cases, and it is more prevalent in males. The male-female ratio is around 2:1. The localization is in the midline. It is intraventricular. It is poorly marginated, and it has strong enhancement, as we can see in this case. The cell of origin is multipotential neuronal stem cells in the ventricular zone of the cerebellar anlage. It is a GABAergic neuron. And there is usually, or very frequently, a MYC amplification that is very important regarding the treatment. The presence of dissemination is very, very high, 50% at diagnosis. You can see here a very typical case of group 3. This is an infant with a midline tumor with a strong enhancement and localized in the midline inside the fourth ventricle with hydrocephalus. Regarding group 4, it's the most prevalent. It represents around 34 to 36% of cases. It generally occurs in children. It is rare in infants. The male-female ratio is 3:1. It is a midline tumor, intraventricular. The margins are very well defined, as you can see in these cases. There is minimal or no enhancement, usually less than 10% of the tumor enhanced, and the cell of origin is in the cell population in the upper rhombic lip that will form the nuclear transitory zone that will eventually form the deep nuclei of the cerebellum. The prognosis is intermediate, and the metastasis pattern is very, very funny because the subependymal metastasis of this group has a mismatch pattern. And then the leptomeningeal metastases are usually concordant regarding the restriction and enhancement pattern. That is what we call match. And they have a tendency to metastasize to the infundibular recess. Here we have a typical group 4 with very, very mild enhancement or no enhancement at all. It is localized in the midline. Let's go now to the metastasis pattern. The metastasis pattern matters because it can help us to decide what tumor we are facing. For example, this tumor is located in the midline, but it is associated at diagnosis with a laminar pattern of dissemination, what we call the sugar coating. And this is very typical of group 3. On the contrary, group 4 is associated with a nodular pattern of enhancement. And as we said, the metastases in the subependymal supratentorial region have a mismatch with regarding enhancement and diffusion restriction. There are very frequently metastases in the infundibular recess of the third ventricle. Regarding the spinal imaging, I have to say that it's very, very important to perform this study before surgery in order to avoid making mistakes with the artifacts that we can find after surgery. There are several patterns. For example, this nodular pattern of METs, very typical of group 4. This sugar coating pattern, very typical of group 3. Sometimes we have to look at the bottom of the thecal sac because sometimes we can find a very small metastasis there that it's very important for treatment. And probably we can use diffusion in this area as well because we can detect these small teardrop metastasis typical of group 4. Let's talk something about the artifacts that we can find here. For example, the pulsation artifacts at the on T2 that we can solve this problem using volume T2. For example, this Fiesta sequence can avoid this confusion. Sometimes after surgery, we can find these spontaneously hyperintense signals in the surface of the spinal cord or within the nerve roots of the coda equina, and they represent metahemoglobin, and sometimes they are associated with arachnoiditis, with clamping of the nerve roots. On other cases, we can find these subdural collections after intracranial hypotension that can occur after lumbar tap or after surgery. And we have to be very aware not to interpret this imaging as metastasis. Well, now we can move on to the differential diagnosis to medullo. For example, these are two cases of the same pathology. On the left, you have a solid mass in the left cerebellar hemisphere. It is associated with strong enhancement, but no restriction on diffusion. And this is very important. On the right, you have the same tumor, but with another with another imaging presentation. This is a solid cystic mass. The solid portion enhanced very strongly, but the cyst just very mildly in their wall, in its walls. And this, of course, is a case of pilocytic astrocytoma. Both cases are pilocytic astrocytomas. I would like to emphasize the importance of be careful with the MRS, because the MRS of these cases look very, very malignant, because they are associated with high choline peak and lactate. But this is a grade 1 tumor. Now it is localized within the circumscribed astrocytic gliomas. Not all of these tumors are grade 1, but well, pilocytic, yes. And it is usually associated with Kia-Bra fusion, which is present in around 90% of cases. The BRAF V600 mutation is present in around 10% of cases, but it is more associated with the thalamic localization of this tumor, and NF1 usually is present in the optic pathway. So the most frequent abnormality at the molecular level is Kia-Bra fusion. Another case, you can see a lateral off midline tumor located in the foramen deluxca with iso-intense or hyperintense signal intensity. The pattern of restriction is heterogeneous, as well as the pattern of enhancement. And this is a typical case of ependymoma. Now ependymoma are divided according to its localization. For example, you can find a supratentorial, posterior fossa, or a spinal cord, and each of them has its different, a particular molecular pattern. Regarding the posterior fossa ependymoma, we can divide them in group A and group B. Group A is, as in this patient, present in infancy. It is lateral in localization, and it has a very bad prognosis. It is usually associated with a histone 3K27 mutation, and sometimes with EZ HIP methylome pattern. It can be grade 2 or grade 3, and we no more talk about anaplastic ependymoma. Here we have a typical case of a group B ependymoma in a 12-year-old boy with a midline intraventricular tumor with a typical caudal tail. And this tumor is not associated with restriction, and it is a relatively benign tumor, group B. Now let's talk something about MRS regarding ependymomas. Sometimes it can help because the presence of a high myoinositol peak is very, very suggestive, but not pathognomonic, because there are other tumors as gliomas that can have this peak. Okay, there are other possibilities. We can find other entities there. For example, in this case, you see a tumor located in the inferior half of the fourth ventricle, adjacent to the inferior cerebellar medullary velum. It is associated with restriction, but the pattern of enhancement is not very strong. This turned out to be an ATTRT, which is a tumor that belongs to the embryonal group, and it can have different types of molecular activation. For example, there is a group that is associated with sonic hedgehog activation that can be located supra or infratentorially. There is another group associated with tyrosine mutation that is predominantly infratentorial. And finally, the MYC-associated ATTRT that can be located anywhere, supra or infratentorial, including in the spinal cord. This tumor is associated with SMARCB1, what before we used to call it INI mutation, and sometimes there is this other mutation as well. Let's talk about some clues on imaging that can help us with this diagnosis. For example, the presence of these peripheral cyst can be associated with ATTRT tyrosine. Sorry, here there is a mistake. These peripheral cysts are associated with this tyrosine mutation. The presence of areas without enhancement within the tumor is associated with sonic hedgehog. And finally, the presence of this band-like at the periphery of the tumor, band-like pattern of enhancement may be found in any molecular pattern. This is another tumor. This tumor is located in the upper half of the fourth ventricle in the midline without enhancement or with very poor enhancement, but with a lot of restriction, some hemorrhages, and this turned out to be an embryonal tumor with multi-layered rosettes, which is another embryonal tumor. It is found most of the time supratentorially, 70% of cases, but we have to bear in mind that 30% of patients of this tumor can be found infratentorially, including in the spinal cord. It usually occurs in infancy, and there is no gender predominance. And the associated molecular alterations are the C19, and sometimes around 10% of cases, DICER1. And it is associated with the presence of protein, which is LING, and this protein is very helpful for diagnosis. Another tumor, in this case, we found this hemispheric cerebellar tumor with a peripheral pattern of enhancement, some irregular restriction pattern, hemorrhage, and this tumor turned out to be a glioma. In that moment, we classified this tumor as a glioblastoma, but now in the current classification, we don't find glioblastomas anymore, so we can classify this tumor as a diffuse pediatric type, high-grade glioma with H3 wild type and IDH wild type pattern. Here we have another tumor. This is a very small lesion located in the inferior half of the fourth ventricle, adjacent to the inferior velum, medullary velum, where it is located the choroid plexus. The pattern of enhancement is homogeneous and there is no restriction on diffusion, but the signal intensity on T2 is low, is iso-intense with the parenchyma, and this turned out to be a choroid plexus papilloma, which papillomas may have these three flavors, and this is the most frequent one, and they are no more considered neuroepithelial tumors, they are considered just epithelial because they have no neuronal progenitor cell. Another variant, another tumors that we can find here, we have two cases of the same tumor. On the left, you have a superficially located small nodules with a strong enhancement surrounded by a lot of edema associated with mass effect. On the right, the same tumor, in this case with another pattern, a solid cystic mass. Look at the cyst, there is no enhancement of the wall, and this is typical of this tumor, as well as the presence of high perfusion. Of course, we are talking about hemangioblastomas, which are not very frequent in infancy, in pediatrics, but we had a couple of cases. 25% of cases in pediatrics are associated with von Hippel-Lindau mutation, which is a very important protein in the activation pathway of the vascular endothelial growth factor. Here we find another case of a hemispheric cerebellar tumor, very hypotense on CT, very hyperintense on T2, and with an irregular pattern and a striated pattern on FLAIR. There is very, very poor enhancement, and you can find these lesions at the level of the skin, in this case, these papules that are very typical of this tumor, which is the dysplastic cerebellar gangliocytoma associated with Lermite-Duclos disease. Now this tumor belongs to this category, the glioneuronal and neuronal tumors, which is a category that is growing more and more in each classification. And the associated mutation is at the level of P10, which is a molecule very important in this PI3K AKT pathway. Well, this is another very, very interesting lesion of the posterior fossa. And there are several lesions that are associated with a strong restriction on diffusion, and they have a peripheral pattern of enhancement, very regular pattern. The periphery of the lesions are hypointense, relatively hypointense on T2. And of course, we thought about abscesses, and we performed MRS, and we found this small peak at the level of 2.4 ppm that represents pyruvate. What we didn't see was this lesion. The surgeons found this small pit at the level of the occipital region, and then we go back to review the CT reconstruction, and we find this very small hole. So this was a case of a dorsal sinus that was complicated with abscesses. All the bacteria that they found there were bacteria of the skin. Well, to finish up, I would like to recommend that you read this paper by our friend Alves from Philadelphia, who published this paper, and this is an algorithm to approach posterior fossa tumor. It's very, very simple and very useful. Well, to sum up, I would like to remind you that we have to use this classification because it's the current one, and we have to, when we face a posterior fossa tumor, we have to think about the location, the ADC pattern, the age of the patient, and other MRI features as the pattern of enhancement. With this, I finish this video. I hope you enjoy it, and see you next week. Bye-bye.